Hey guys, and welcome to our channel where we'll be covering all things OT and all things hand and upper extremity. Our goal for this video is to give you the upper hand without understanding pathologies and other conditions, whether you're a practicing therapist, therapy student, or someone who's just wanting to know a little more about what's going on with you or someone you know. This will be a great comprehensive review, and we'll throw in some tips and tricks to help you be able to better treat your patients who may suffer from this condition. We hope this video is beneficial to you and that we're able to clear up any misunderstandings or questions that you may have. So join us as we dive in and learn all about carpal tunnel.
Guys, before we go any further, please take a moment to like this video and subscribe to this channel. This will help us bring you more content like this in the future. So I'm Parker, this is Dylan, and we are two hand therapists from Mississippi.
Wait. If you're not from Mississippi, don't leave and know what you're thinking. What could you possibly learn from someone from Mississippi? Stick around and you'll be glad you did.
Alright, let's jump right into it. So you may be wondering, what in the world is carpal tunnel?
Or you may know what it is, but you may be experiencing it and you want to get rid of it.
Or maybe you have an upcoming test and you want a quick refresher to help you ace the exam. If any of these apply to you, we feel like you will benefit from watching this video. Enough blabbering. Carpal tunnel, let's start there. Carpal tunnel, C-A-R-P-A-L. We hear a lot of times copper tunnel. This has nothing to do with any type of metal. So, in most patients, carpal tunnel syndrome gets worse over time, so early diagnosis and treatment are very important. So if you're watching this video and you think you may be suffering from it, then pause the video and perform this motion for 1 minute. This is called the Phalen's test, and this test is positive and indicative of carpal tunnel syndrome if you experience numbness, tingling in the digits within this minute, specifically the thumb, the index, the middle, and half of the ring finger closest to the thumb. We will learn more about this later in the video. So a more reliable way to diagnose carpal tunnel syndrome would be to actually have an EMG or a nerve conduction study performed, which measures the electrical activity of that specific nerve you're testing, which in this case is the median nerve.
So carpal tunnel syndrome is a compression neuropathy that causes numbness, tingling, and possibly even weakness in your hand, any combination of these. Potentially. This happens because of pressure on your median nerve, specifically in the area of the carpal tunnel, and you can have median nerve compression on other areas of the median nerve in the upper extremity, like in the elbow, but that's known as pronator syndrome, and that's another video for another day.
Symptoms of carpal tunnel are going to include paresthesias, which you heard us talking about, numbness and tingling, and that's in the median nerve distribution we mentioned earlier, which is going to be the thumb, the index, the middle, and then the radial half of the ring finger, all on the volar surface. Symptoms often occur at night, and that's because people oftentimes sleep in a very curled up position, which is going to put a lot of pressure on that nerve. Now, both of these are sensory issues. However, if left undetected or untreated for long enough, it can actually cause atrophy to the thenar musculature, as this nerve does have both a sensory and a motor component. Oftentimes, if this has occurred, you will hear people complain of dropping things.
It's extremely important to know your anatomy, so let's take a second to review that. First of all, the median nerve is derived from the medial and lateral cords of the brachial plexus up towards the shoulder. You may remember that. So you can have compression at some other location up the chain, as we talked about, up the median nerve versus all the way in the wrist, distally at the carpal tunnel.
Yeah, so we know that the carpal tunnel is located on the palm side of the hand, which is actually the floor of the carpal tunnel. The roof of the carpal tunnel is going to be your transverse retinacular ligament. It's also bordered on the sides by carpal bones. On the ulnar side, you've got your pisiform and your hamate. Your radial side, you've got your scaphoid and trapezium. So now let's talk about the contents of the carpal tunnel. You have a total of 10 structures that run through the tunnel. You have 9 tendons and 1 nerve. Okay, you have 2 tendons running to each finger, index, middle, ring, and small. And then you have 1 tendon running to the thumb. The tendons running to your digits 2 through 5 are going to be your FDS, which is flexor digitorum superficialis, and that tendon inserts on the middle phalanx, which controls PIP joint flexion. And you also have the flexor digitorum profundus, which runs all the way to the distal phalanx. And with the thumb, you have the flexor pollicis longus, or the FPL, And of course you have the main culprit, which is the median nerve.
Now what does it mean if someone has been diagnosed with carpal tunnel syndrome? That means for whatever reason there's pressure on the median nerve at the carpal tunnel. So what happens when you have pressure on a nerve? It goes to sleep, meaning you have a numb or tingling feeling, that paresthesia term we talked about earlier. We have all sat on a leg the wrong way for too long, and your foot goes to sleep, your leg goes to sleep, and you have the pins and needles feeling. Well, when that happens, you have too much pressure on a nerve, so the first thing you do is either stand up or reposition to relieve that pressure from the nerve. And that's great that we can relieve it with a short period of time, but some people with carpal tunnel syndrome will tell you that repositioning doesn't always work to fix their problem.
So, and I like to use the water hose example. It just makes sense to me. So you have a water hose that is running, and there is a constant flow of water that is coming out of the other end of that hose. That is going to be the electrical activity of the nerve giving and receiving signals to, in this case, all the way to the tips of the fingers. If someone steps on that water hose and puts a kink in it, that is going to limit the amount of signals that are making it to the tips of your fingers. Now, if that foot is taken off of the water hose and that pressure is relieved, it will slowly start resending those signals normally again.
So the question becomes why there's not enough room for the nerve in the tunnel when there's been enough room all your life. It could be something that you're doing, like performing activities in a prolonged or repetitive wrist extended or flex position, which can put pressure on the nerve. So as we see, as Parker's drawing a line where the median nerve is located in the carpal tunnel, and Parker, if you could demonstrate a wrist flexed posture.
So you can see immediately just by looking at the line that this would certainly put pressure on that nerve.
And so a real world example of this would be like a mechanic or someone at a desk typing or writing with bad ergonomic setup where they're in that flexed posture or something of that nature. Parker, if you could go to the other extreme and place your wrist in full extension.
So again, just looking at this line, you can see that this would put a pretty big stretch on that nerve, and I certainly wouldn't want to stay in that position for a long time. Just think about a rope being pulled around a sharp edge or a sharp turn. If this happened for long enough, that would certainly put a kink in that nerve. Or if it is done repeatedly over and over and over again, just think about the damage it could cause to that nerve.
So a common example here would be a waiter or a waitress carrying their heavy tray, for prolonged periods of time. Now, power and repetitive grip could also lead to compression of that median nerve due to your flexor tendons running through the tunnel becoming taut during digital flexion when you're flexing everything down. Anything with vibration, such as a weed eater, jackhammer, any kind of vibratory tool, along with prolonged grip, could also lead to compression of the nerve.
And I have to say this before we go any further. Some people, for whatever reason, are more susceptible or predisposed to getting carpal tunnel than others. So, for example, Dylan could be performing a desk job for years and never have any issues, and then I could start that same job and within a month already be exhibiting some symptoms. So it's not always necessarily the job itself. They now know that it's most likely a congenital predisposition, which just means it runs something that runs in the family.
And pregnant women actually are more predisposed to having carpal tunnel syndrome. And why, you may ask? Well, they retain fluid, and if there's more fluid in an already small area, more the likelihood is for that nerve to run out of room or to be compressed. However, this does typically go away once the baby's delivered, so it's typically treated very conservatively in this case.
So trauma can also cause carpal tunnel syndrome. So take, for instance, a Colles fracture, which is a distal radius fracture, or most people will just say it's a broken wrist. You will see some surgeons just go ahead and do a carpal tunnel release if they're already in there doing an ORIF to correct the distal radius fracture. But that's a different topic for another day, which we will be doing a video comparing a Colles fracture versus a Smith's fracture, and you will not want to miss that. So again, don't forget to subscribe.
So now getting into treatment, we will start with the most conservative measures and then progress towards surgery. So first off, you're going to want to educate your patient. They need to be avoiding repetitive or prolonged wrist flexion and extension. Could they possibly need an ergonomic work assessment to check positioning on the keyboard and monitors? Maybe. Do they need bigger handles on a frequently used tool at work? This is also another possibility.
Typically the easiest way to keep from doing those things that he just mentioned is just to splint the wrist. I do see some people come in with a wrist and thumb immobilization splint, and I never like immobilizing a joint unnecessarily. So for carpal tunnel, just a wrist immobilization splint will work. You will want one that will keep the wrist in neutral So for when you may be typing or performing some strenuous activity, or even sleeping, because remember how a lot of us like to curl up when we sleep. And I have to say this because I've seen it a million times. A patient will come in our clinic after failed conservative treatment elsewhere, or they were just trying to treat it themselves, and I will ask, well, what were some of the things that they had you working on, or the things that you may have been doing at home? And without fail, I would hear the word so remember what we just said, avoid repetitive grip. This will do nothing but make it worse. Now, if we're seeing them post-op, of course they're going to be getting putty, but conservative treatment should never include any type of putty exercises.
So median nerve glides are another good tool to use, another good exercise. As they move the nerve through the carpal tunnel, they kind of glide things, kind of almost get things unstuck, if you could say it like that. There are examples out there on Google. You have to be careful, obviously, what you find on Google, but there are some examples there, and we may cover some more in detail in a future video as well.
So also, he mentioned nerve gliding. Now, tendon gliding. Remember, the tunnel has 9 tendons that cross through that tunnel with the nerve, and tendons are much easier to move since they are actually connected to a muscle. The theory here is that if you can individually move a tendon through that tunnel, that it could possibly help loosen things up some.
So ultrasound or phonophoresis can also be helpful. Also, since carpal tunnel syndrome is an inflammation issue, the doctor may place the patient on oral anti-inflammatory to help reduce the swelling or the inflammation. The problem with this is that, yes, you'll get some benefit, but the medicine doesn't know to target just the carpal tunnel. It's non-specific, and so it's also going to help your swollen ankle or knee if you have that, just as much as the wrist or hand. So a way to help target that inflammatory medicine is a possible injection of corticosteroids that your doctor may administer, which could help with the compression they were experiencing.
Some people, though, are deathly afraid of shots. So one last option that your therapist could do would be onpheresis, which is, again, another delivery of a drug through the skin with a light electrical current. So we typically use dexamethasone, as it is an anti-inflammatory medication, and this can be pushed into the carpal tunnel area with some success with mild cases. Onto is much stronger than an oral anti-inflammatory, but it is much weaker than the level of an injection at the MD's office. If all or some of these options fail to give you the relief that you need, then you're more than likely looking at either A, living with it, which we don't recommend, or B, progressing towards surgery.
So let's talk surgery. So there's 2 main options at present. There's the open carpal tunnel release or an endoscopic carpal tunnel release. They're both doing essentially the same thing, which is cutting through the transverse carpal ligament, which is also known as the flexor retinaculum. You're basically taking the roof off of the carpal tunnel. We won't go into a ton of detail in this video regarding the surgeries, but basically an open carpal tunnel release is when they make a small, about 2-inch incision over the wrist or palm area, and they visually find that ligament, carefully cut it. The endoscopic method requires a smaller incision that's slightly proximal to the wrist level, and instruments used that has a camera and a small blade that will cut that transverse carpal ligament. And we won't argue what surgery is best, because we usually have great results with either in therapy. We also sometimes do get the question, can this reoccur? Typically no, but there is a very small chance yes, although this is not typical.
So let's wrap it up with a few treatment tips and pearls. So first visit, if somebody's come in and they've had surgery, we're going to want to see if their sensory issues have improved. Sometimes they're going to say yes, completely. Sometimes they're going to say some better, but not fully. And if that's the case, then I'll usually go back to my water hose example again. So when you take your foot off of that water hose, it is not immediately going to start coming out the other end. It may take a while to get back to a normal flow again.
Another thing that you may hear sometimes is that your patient may say, hey, I'm still hurting after surgery. They may say they're hurting in a different way after surgery. That does happen sometimes. I use that time to educate a patient that, even though the carpal tunnel syndrome was taken care of, you still had a surgery, you still got cut on, and your body doesn't really know exactly how to respond to that trauma because it was not planned. It just happened, and so it knows it got cut, so it starts the typical healing process, which does sometimes elicit some pain.
We sometimes hear our patients complaining of pain on either side of the palm, right here, and this isn't rare, and I'll have Dylan demonstrate for us with this rope that we used earlier. So Dylan, if you'll grab that rope. So he's going to hold this rope pretty tight and act like he is gently trying to pull it apart, which is basically what the transverse carpal ligament is doing. So when the MD goes in there and they'll take that ligament and cut, you notice how his hands automatically just kind of pulled back. So it's going to do exactly what you would expect, and it bounces back to where it's being pulled from. And sometimes this can cause bone bruising. So that is typically what the patient is feeling, and we just try to reassure them that this should last no longer than about 6 to 8 weeks or so.
And for carpal tunnel release surgery, there are really no post-op precautions necessarily, but you can certainly aggravate the tissue if you try to progress a patient too quickly. We typically don't start strengthening with putty or wrist strengthening until about maybe the 3-week mark to allow that tissue to properly heal. So our return to work goals are usually 6 to 8 weeks time frame, if not sooner, depending on their job demands.
So if their scar is bothersome, of course we can perform some scar tissue massage, and that could be just used with your finger, of course, or some type of Graston instrument or other type of instrument. A Celastic scar pad is good to help soften that scar, even a 50-50 elastomer. If you don't know exactly what those are, then again, just stay tuned. We're going to upload a video at some point about nothing but scar management that you'll definitely want to make sure you tune in for.
So edema management will also be maybe a focus after surgery, and that'll include retrograde edema massage, ice, elevation, edema gloves, or some type of compression sleeve, as well as an IFC, interferential current, or high volt treatment. So overall goals are to reduce pain, reduce swelling, regain or maintain full range of motion, regaining strength, and regaining just full function of the hand and wrist and upper extremity with return to work or a prior level of function as the overarching goal.
I mean, wow, talk about information overload. But we hope you learned something today. We'll be doing videos on many different topics, diagnoses, custom splints, and different tips and tricks that we have learned over our years of practice. So please, again, go ahead and like this video, subscribe if you haven't already. Drop us a comment in the bottom if you've experienced carpal tunnel, if you know somebody that has, or if you know of a tip or a trick that may have worked well for you guys that we didn't mention today.
We hope you guys heard something that helps your practice, that helps your general level of knowledge, and I hope that you can use this information to give you the upper hand. So we'll see you guys next time.